already said, is Mori Arkin. I'm a pharmaceutical veteran. And in the final stage of my career, I've chosen to dedicate myself to one of our portfolio companies, Soldier Technologies, which develops orphan drugs for ultra-rare dermatological diseases. Having grown more familiar with orphan drugs, I tend to believe that this important segment of the pharmaceutical market, notwithstanding its own challenges and complexity, is particularly attractive for our biotech industry in Israel. In Israel, we have the scientific and medical resources that are needed to excel in R&D of rare diseases, as well as experienced and reputable clinical infrastructure. Importantly, the cost of full-scale development of an orphan drug is more achievable for Israeli biotech companies, which are so often unfunded, unfortunately. In the following remarks, I will provide a short overview of the orphan drug landscape. I will also touch on the underlying moral dilemma of healthcare decision makers. How does a compassionate society balance the imperative to provide the best possible therapy to every individual, and when such therapies do not yet exist, to foster innovative treatment development, with the reality of the disproportionately high cost of these treatments. The regulatory framework for rare diseases have evolved significantly in response to patient needs, which were historically neglected due to the lack of research incentives. Prior to 1983, a milestone year for orphan drugs, pharmaceutical companies largely ignored rare disease because development costs of drugs for these diseases were considered too high compared to their expected profitability at that time, not now. This began to change in 1983 when the United States passed the Orphan Drug Act, encouraging drug development diseases affecting fewer than 200,000 people. The act provided market exclusivity for 7 years, tax credits for clinical testing, and waived fees for regulatory applications. Since then, other countries have implemented similar legislation, spurring a significant increase in orphan drug development. Additional support programs, such as the fast track and breakthrough designations, and FDA willingness to grant conditional approval for specific drugs based on surrogate endpoints and wait for clinical data to be collected post-approval, has played and will play in the future a pivotal role in this evolution. Thanks to these initiatives, the orphan drug market, almost non-existent at the last century, has grown rapidly in the 21st century. In 2023, orphan drug sales reached approximately $240 billion out of a total pharmaceutical market of $1.6 trillion, about 14.6% of the market. By 2032, sales are projected to hit $500 billion. This is half a trillion, making up 18% of the global market, expected to reach 2.8 trillion. In fact, the compounded annual growth rate, the CAGR, for orphan drugs is expected to be nearly double that of the general market, around 11% versus 6.4%. These were quite surprising numbers when I prepared my lecture, and I guess possibly also surprises some of you. There is a vast number of rare diseases waiting for effective therapies, not merely supportive treatment that alleviates symptoms, but drugs that address the root cause of the disease. Advances in genetic testing, such as whole genome sequencing, combined with global scientific collaboration, are enhancing our understanding of existing conditions and leading to the discovery of new rare diseases. Many of these disorders are linked to single gene mutations, and breakthroughs in gene therapy, gene silencing, and gene editing are likely to spur the development of numerous new treatments. How many rare diseases are there? Estimates vary, with some suggesting there are as many as 6,000 rare diseases, and rare disease associations claim that 300 million people worldwide are affected by rare diseases. So it's a huge number and a huge variety. The spectrum of rare disease is wide, ranging from conditions that affect nearly 200,000 individuals to those impacting only a few dozen patients. So increased awareness is another major driver of this market growth. Patient advocacy group play a crucial role in promoting recognition of rare disease. They lobby for research funding and pressure regulatory agencies to approve drugs even when the supporting data may not be entirely conclusive. These groups argue that regulators should, in some instances, give these drugs the benefit of the doubt, as they might be the only hope for patients and their families. However, this advocacy is a double-edged sword. Approving drugs with limited efficacy can strain budgets that might otherwise be directed towards more effective therapies. The commercialization of orphan drugs by large pharmaceutical companies leads in many cases to the discovery that some diseases are actually much more prevalent than originally thought. Companies educate physicians about rare disease, provide them with diagnostic means to identify the disease, and create awareness of patients through social media. A notable example is amyloid transthyretin cardiomyopathy, the ATTR known disease. A few years after the launch of a specific therapy by Pfizer, the actual prevalence was found to be more than 10 times higher than originally estimated. All these factors, scientific advances, societal compassion, regulatory support, and commercial drive, together with high prices, have led to a steep increase in the rare diseases market. But how high is too high? This is an ethical question that each society must answer in its own way. Two key considerations in drug pricing are a country's economical capacity and the drug's cost effectiveness. A price acceptable in the US or Europe might render a drug unaffordable in India or Africa. Companies that insist on uniform global pricing risk depriving millions of people of potentially life-saving or life-altering drugs. Even in developed countries, however, there is a ceiling on what payers are willing to pay. To help determine appropriate pricing, several research institutes, such as the American Institute for Clinical and Economic Review, ICER, and the British National Institute for Health and Care Excellence, NICE, have developed frameworks to assess cost effectiveness. They calculate the health benefit of a drug in terms of a quality-adjusted life years. Each quality of life, adjusted year represents a year lived in perfect health. For example, a drug that costs $100,000 per yearly treatment, but only delivers 50% of a perfect year of health, is calculated at a cost of $200,000 per quality of life adjusted year. This type of analysis, although a bit elusive and a bit tricky, can sometimes reveal that drugs appearing inexpensive may actually be costly, and vice versa. In this respect, the growing wave of gene therapies represents a particular problem. Gene therapy, like for hemophilia B, Duchenne muscular dystrophy, and others, cost more than $3 million, which should be paid upfront by the insurer. Their cost effectiveness, on the other hand, depends on the durability of the benefits of the treatment. They may not be so expensive if the benefits are substantial and persist for many years, but at present there is not enough data to determine the time span of their benefits. So the insurers will have to make a decision based on limited set of data. Notably, there is substantial difference in the cost-effectiveness criteria between countries. While the US may accept cost-effective prices between $50,000 and $150,000 per quality of life adjusted year, the UK generally limits expenditure to around £30,000 per quality of life adjusted year, except under special circumstances. Let me now illustrate with specific cases how market prices can far exceed the recommended cost-effectiveness thresholds and create blockbuster drugs opportunities. ATTR cardiomyopathy, which was already referred to, Pfizer drug tafamidis is priced at about $250,000 per year treatment. Yet to meet ICER cost-effectiveness threshold of $100,000 per quality of life adjusted year, ICER maintains the price would need to be around $16,500, a discount of 92%. This gap is staggering when multiplied by the number of patients. Pfizer has already generated from this tiny little orphan drug $6 billion in yearly sales, with forecasts predicting total ATTR drug sales could peak at $20 billion, figures comparable only to drugs like Humira or Keytruda, which serves millions of patients or hundred thousands of patients, many hundred thousands of patients, or millions. Cystic fibrosis, Vertex treatment for cystic fibrosis has dramatically improved patient life by expanding lifespan and reducing hospitalization. Vertex currently treats 70,000 patients worldwide, and its drugs generated approximately $10 billion in sales, more than 3 times the total pharmaceutical consumption of Israel. Although the clinical benefits may justify the cost, the sheer volume of spending has sparked significant confrontation in the UK between Vertex, healthcare providers, and politicians, even leading to threats to revoke Vertex patents. Ultimately, a confidential price settlement was reached, demonstrating that determined payers can secure cost reductions. Now the final example, dystrophic epidermolysis bullosa. This ultra-rare condition causes fragile, wound-prone skin that results in severe, often painful wounds and injuries. Crystal Biotech recently launched a topical gene therapy for about 1,000 eligible patients in the United States. While the treatment improves wound closure, reduces infections, and cuts down on the time required for bandaging from few hours to less than an hour, its average annual cost is approximately $650,000, with a lifetime cost per patient estimated between $15 million to $22 million per patient. So as you can gather from these few examples, in orphan drugs, size is not so important, and even very small indications can yield, with the right price strategy, good returns for the developing company. Now let me come to my concluding remarks. With this example, and these are only very few examples, even if in the future the more exaggerated prices will be pushed down, the need for orphan drugs will grow immensely, because at present only less than 10% of rare disease patients have a treatment for their affliction. Israel should join the rest to discover the remaining 90% of new therapies, and Israeli policymakers should explore ways to foster entrepreneurship in the orphan drug space. Thank you.